welcome to, I think will be the 10th episode that I'll be publishing on YouTube. So this will be amazing. I think it's almost 9 weeks since I started this project, and it's coming along really well. And as you know, the incentive of why I'm doing what I'm doing, why I'm here on a Saturday afternoon when I believe it is bright and sunny outside here in Melbourne, is that I'm trying to raise money to support two great causes, the Asylum Seeker Resource Centre and the ANZCA Research Foundation. And next month, I think I've decided to support, on behalf of Lahiru, who does the podcast with me, the Fred Hollows Foundation, as well as the ANZCA Research Foundation, because I'm going to try to get Lahiru to come and do some sessions here as well, because he is an expert in the mental side of things. And I think that will be a very interesting and important session for everyone who is involved with the Patreon page. Now, the framework we're going to use is to make sure that we stimulate your thought processes, get you excited and facilitate attention to detail and really assist your brain in creating some long-term memory, especially for this exam. Well, when I say long-term, it's all relative, isn't it? Long-term, long enough to get through the exam and pass the exam. Now, the breakdown of the SAQs. So we're going to review the examiner's report. We are going to do a literature review, or I'm going to show you where I get my information from. We'll present the key concepts, and then after that, I'll go through any questions that you guys have, and we'll have an answer structure, or I'll sort of show you my answer sort of structure, and then we'll write an answer at a time. So from the primary answer course that we did a fortnight ago, we've gone through controller breathing. And then after that, we've done the muscles of respiration, the work of breathing, which includes compliance, resistance, and hysteresis, or the time dependence of pulmonary elastic behavior. And last week, we went through fast and slow alveoli, physiological dead space, which includes both anatomical dead space and alveolar dead space. And today we will be going through diffusion. So this is the question related to diffusion. And this was asked in 2003, question 12. Explain the difference between perfusion limitation and diffusion limitation in the transfer of gas between alveolus and pulmonary capillary. Outline the factors that determine whether gas transfer is perfusion or diffusion limited. This was the examiner's report. So the main points expected were a definition and explanation of both perfusion limitation and diffusion limitation, as well as a description of the factors included in Fick's law of diffusion. It was expected that candidates would provide some indication that diffusion limitation implies that the equilibration of gas between alveolus and pulmonary capillary is incomplete. And I think that is a very important statement, that when we do come to define whether a gas is perfusion or diffusion limited, we need to use these terms. So we need to talk about the equilibration of gas between the alveolus and pulmonary capillary. Now, the factors affecting whether a gas is perfusion or diffusion limited included the solubility of the gas, its partial pressure gradient, and the transit time blood through alveoli. It was expected that examples would be given and that carbon dioxide, OMG, very controversial, but we will work through this. And I'm sure this is why all you guys are here today, to find out what carbon dioxide is. And that carbon dioxide and oxygen transfer would be correctly categorized. Additional marks were given for explaining the significance of the binding of the gas to hemoglobin, and for discussing the effects of increased cardiac output and increased altitude on the transfer of oxygen. a graph comparing the changes in red blood cell partial pressures of carbon dioxide and oxygen during its transit through the pulmonary capillary attracted extra marks. I have never seen a graph for carbon dioxide with this, as in when I say that, carbon dioxide in a prescribed textbook for this diffusion question. But we are going to work it out. Now, marks were given also for commenting on the transfer of carbon monoxide and for explaining that this is used to measure gas transfer. This is what we should not do. So many candidates fail to provide definitions for perfusion and diffusion limitation, or provided incorrect or opposite definitions. Others incorrectly categorize carbon dioxide and oxygen. Many candidates commented on nitrous oxide or carbon monoxide transfer without discussing carbon dioxide and oxygen. This is difficult because nitrous oxide and carbon monoxide would be the most common gases that you would see as examples for describing whether a gas is diffusion or perfusion limited. Okay, so what makes this question even more challenging is that they want to talk about carbon dioxide. Others failed to mention the factors included in Fick's law, thereby reducing the total marks possible. This is a summary of the exam report. So I think to get a good pass, you need to have a good definition of perfusion and diffusion limitation, and in that correctly categorize carbon dioxide and oxygen. Then we need to have a discussion of Fick's law of diffusion and the factors that determine whether a gas is perfusion or diffusion limited. And this will include things like the partial pressure gradient, the altitude, and the transit time. And you would get a good pass or extra marks if you included these other aspects, which include a discussion about hemoglobin affecting the diffusion of oxygen, cardiac output as well, and examples with graphs using CO2, carbon dioxide, and oxygen. And we also, if we can have time, using carbon monoxide to measure a statement that says carbon monoxide is used to measure diffusing capacity. So lots there to unpack. These are the two core texts that I'll be using, that I've used. So I've used from Nunn's chapter 8, Diffusion of Respiratory Gases, and West chapter 3, Diffusion. Now, given what the examiner said, the way to define whether a gas is perfusion limited or diffusion limited is to look at the alveolar and pulmonary capillary gas. So when a gas is perfusion limited, the uptake of gas is dependent on blood flow. And the clue with that is that when you look at this, this word here, perfusion limited, just think blood flow. And therefore you can say that the uptake of a gas is dependent on the perfusion, but instead of using the word perfusion, use the word blood flow, okay? And then the other thing is that the alveolar gas, the partial pressure of the alveolar gas, the partial pressure of the alveolar gas will be equal to the partial pressure in the pulmonary capillary. So you get equalization. So when you get equalization, a gas is perfusion limited. And because of this concept here, where alveolar gas is the same as N pulmonary capillary gas, we can make the assumption that nitrous oxide is perfusion limited, oxygen is perfusion limited, and therefore carbon dioxide is perfusion limited. Because remember, at the end of the pulmonary capillary, the alveolar CO2 will pretty much equal the end pulmonary capillary CO2, which then equals your arterial CO2. Okay. So that's how we can conclude that CO2 is a gas that is perfusion limited, but it is a lot more complex than that. But I think for all intensive purposes for this answer here, this is where it sort of fits in. All right. Now, the definition of diffusion limited. So again, when you think about this question here, think about diffusion. So it's going to be limited by the diffusion capacity. And then instead of using the word diffusion, just use the word a membrane diffusing capacity. So the uptake of gas is dependent on membrane diffusing capacity. And this is where the partial pressure of the alveolar gas is more than the partial pressure at the end capillary, at the pulmonary end capillary. Okay. And the classic example here is carbon monoxide. And it also occurs with oxygen in pathological states, which can be exacerbated with exercise and or altitude. And there's a couple of diagrams in West which shows this quite nicely. Now, it's based on Fick's law, and Fick's law is the net rate of gas transfer equals surface area divided by thickness multiplied by the solubility divided by the square root of the molecular weight of the gas multiplied by the partial pressure gradient. As you can see, the reason why I've written it this way is because for me it's, and this is, you can write it sort of however you want, but the reason why I've done it this way is because this bit here, the solubility and the molecular weight, for me is fixed, okay? And therefore, these just act as prompts for me to know what to discuss in the answer, right? So I need to discuss any pathologies that affect the surface area, the thickness, and the partial pressure gradient. Now, this bit here, all right, this whole bit here is known as the diffusing capacity of the lung membrane in mils per minute per millimeters of mercury. And I think this is where it gets a little bit complex, all right? So try to sort of follow this, because this is where I think this is a really sort of complex conceptual process where we're going to have to think about the diffusing capacity of the lung and also the diffusing capacity of the lung membrane. So in other words, the concepts here are both DL and DM. So DL is the lung and DM is the membrane. And you'll see these two terms labeled in both Nuns and West. And where it gets confusing is just the way they've sort of described it. So we'll try to go through this slowly. So the diffusing capacity of the lung equals the net rate of gas transfer divided by P1 minus P2, or the partial pressure gradient. And that is just a rearranging of Fick's law of diffusion. In other words, all I've done is that with this formula here, I've gone net rate of gas transfer equals DL times P1 minus P2, okay? And therefore, I've just defined DL in terms of net rate of gas transfer divided by P1 and P2, but not how I've used DL, whereas up here, I've said that that was actually DM. So why do you see this formula and you'll see this formula described as such in West? Well, the reason for that is that it's just a simplification. So if a gas does not react with hemoglobin, the diffusing capacity of the lung will equal the diffusing capacity of the lung membrane, because there is nothing else affecting it. Otherwise, you will see this formula being used, and you'll see this formula being used in both West later on, and also in nuns, where the diffusing capacity of the lung, so 1 over DL, because it's about capacitance now, so that's why it's the inverse. 1 over the diffusing capacity of the lung equals 1 over the diffusing capacity of the lung membrane, which is this here, plus 1 over theta, which is the rate of reaction with hemoglobin, multiplied by the volume of capillary blood. So let me just repeat that concept again. If a gas does not react with hemoglobin, the diffusing capacity of the lung equals the diffusing capacity of the lung membrane, because there's nothing else that is going to affect the movement of gas from alveolus to the blood. But if it reacts with hemoglobin, and the gases that react with hemoglobin are carbon monoxide and oxygen, and also CO2, okay? You're going to have to use this formula here for those gases. So when you talk about carbon monoxide, oxygen, and CO2, use this formula here. But for other gases which don't react with hemoglobin, you can assume that this formula is all you need to calculate the diffusing capacity of the lung. And what we'll do is I'll go through a worked example of how they do this in the next slide. Now, normal DLCO, which is the normal diffusing capacity of the lung for carbon monoxide, is 25 mils per minute per millimeters of mercury, and that is from West. Okay. The thing to note is that the diffusing capacity of carbon monoxide through the membrane is 0.8 times that of oxygen. So just be aware of that. So, but hemoglobin's affinity for carbon monoxide is 250 times that of oxygen. And that is actually why carbon monoxide is used, because it's actually pretty close to, when you calculate what the DMCO for carbon monoxide is, it's pretty close to what oxygen's is, okay? Now, we're going to be talking about the reaction with hemoglobin. So these are the factors that affect diffusion of oxygen and carbon monoxide. They are the diffusing membrane. So diffusing membrane, and remember, those things are affected by your surface area divided by your thickness, and to a lesser degree, because these is already fixed already, the solubility of the gas, solubility divided by the square root of the molecular weight. Okay. Now, the other thing that we need to think about with oxygen and carbon monoxide is that it reacts with hemoglobin, and that's defined by theta. In other words, so this diagram here is showing you that this hypothetically is oxygen. Oxygen has to pass through this layer of tissue here, which they've defined as a DM. And then the uptake of oxygen has to do with the rate of reaction with hemoglobin, defined by theta. And as you can see, when you've got more hemoglobin, you can have more oxygen picked up. And that is defined by the volume of capillary blood, as well as the component, the concentration of hemoglobin, which we'll talk about, okay? Now, in the example below, where you've got a patient with less volume of capillary blood or less hemoglobin concentration, you can see how that affects the diffusion of oxygen. Because once oxygen has diffused through the alveolar capillary membrane, because there's less hemoglobin there, there's actually less uptake of oxygen. And that is why when you see respiratory function tests, you will see DLCO corrected. What is it corrected for? It's corrected for hemoglobin. And that is why it explains that hemoglobin affects your solubility of oxygen. Now, remember what I said was that to calculate the diffusing capacity of the lung, you have 1 over DL equals 1 over DM plus 1 over theta multiplied by the volume of capillary blood. We also know that when we test for the diffusing capacity membrane, we often use carbon monoxide. And so from the previous formula before, we know that the diffusing, the diffusing capacity of the lung equals the amount of carbon monoxide taken up divided by your alveolar carbon monoxide. We don't need to have arterial carbon monoxide because it's so avidly taken up. The partial pressure of arterial carbon monoxide is negligible. So what they do is they know the carbon monoxide consumption or the net rate of transfer of carbon monoxide. They know what the alveolar carbon monoxide is. So at steady state, they're able to measure the mouth pressure or the end-tidal carbon monoxide, which is representative of the alveolar carbon monoxide. And from there, they're able to calculate what DL is. And this is what they calculate. Now, the thing that you also should know about is that the rate that carbon monoxide reacts with hemoglobin depends on the oxygen saturation. And that is why patients with carbon monoxide poisoning, you're always told to give supplemental oxygen in order to displace carbon monoxide. In other words, that as your saturations drop, the rate of reaction with carbon monoxide increases. And so these are done by studies, and they pretty much can figure out what it is based on, based on those studies. You can actually figure out what theta is. So these become two known values so one from working out this formula here, and this one from working out through the table. And what they do is they do an experiment where they have they use different concentrations of oxygen, and then you got two simultaneous equations, and then you're able to solve, because you got two similar equations, both the volume of capillary blood as well as the diffusing capacity lung membrane. And that is how they make that distinction between diffusing capacity of the lung and diffusing capacity of the lung membrane. And I think this is where conceptually it's quite hard for trainees to explain, because when we think about carbon monoxide and we think about oxygen, it's not just about the lung membrane. It's also about hemoglobin and about the rate of reaction with hemoglobin, as well as the volume of capillary blood, okay? And its relationship is described with this formula here. So that's why you'll see this formula described in West after, and as well as in nuns. My little boy's back, and my dog's very excited to have him home. So apologies about that. Okay, now diffusion impairment of oxygen occurs with a reduction in solubility in the alveolar capillary membrane. So anything that affects the DM. So this is decrease in surface area, increase in thickness, or a decrease in the partial pressure, such as altitude. And then anything that decreases the reaction rate with hemoglobin. And really, what I mean by that is really a reduction in the capillary transit time. So it requires 0.25 seconds for equilibration. And with exercise, that can be reduced, but it only becomes a problem if there is pre-existing abnormalities, and we'll show that in a diagram. The other thing that you guys should know is that, yes, exercise reduces the diffusing capacity in patients with abnormal lungs, but in patients with healthy lungs, exercise actually increases your diffusing capacity, because exercise increases the volume of capillary blood. And there's also that process of recruitment and distension, and then you get extra perfusion of alveoli at the apex, improving uptake of oxygen. So remember, in normal lungs, exercise increases the diffusing capacity. In abnormal lungs, exercise reduces your diffusing capacity, and therefore changes the dynamics of the gas, so much so that oxygen can go from perfusion limitation to diffusion limitation. Now, the other concepts are that diffusion impairment of oxygen also occurs with a reduction in volume capillary blood, and also reduction in your hemoglobin as well. Now, oh yeah, so I've just got these graphs here. So these are the graphs from West, and have a think about what you want to draw for the exam, because it is a bit of a challenge, I think, to draw both graphs, and you may decide to draw one or the other and maybe explain the concept. So the concept here is that you've got normal alveolar to arterial equalization representing perfusion limitation. And then in these states here, where you have some abnormalities, so such as a reduction in surface area or increased thickness in the lung because of a disease process, that with exercise, you can see that at this point here, your arterial or pulmonary capillary oxygen is less than your alveolar. So when your PaO2 is more than your pulmonary capillary O2, that means that gas becomes diffusion limited, okay? But when your alveolar O2 equals your pulmonary and capillary O2, that equals perfusion limited or limitation. And it's sort of analogous, it's sort of exaggerated during altitude. So at altitude where you've got half the alveolar pressure, what you'll find is that patients with abnormalities, they become, or in fact, even in normal states, they become perfusion limited, but it's grossly exaggerated during exercise. And even in normal patients at altitude, they become perfusion limited. So those would be the scenarios where oxygen goes from perfusion limitation to diffusion limitation. All right. Now, this is the graph that I would probably draw at the start. And the reason why I would have this graph here is because it's got representation of carbon monoxide, it's got representation of nitrous and oxygen, as well as the abnormal states. And what I would do is I'll probably superimpose the exercise line here, okay? And look, I think this is a very personal decision on which graphs you want to use, whether you want to use this graph here, or a combination of this graph, or whether you want to use this graph. I think what you can do is you can just try out and see what you can actually reproduce in the 10 minutes. Now, we have to figure out carbon dioxide. So let me get my ruler. Yeah, it's here. Okay. Now, the thing with this graph here, so I always look at the axes, and these axes here are unlabeled, but this one here represents alveolar partial pressure. And my assumption here is that this would be 100, all right? So I'm assuming that this is 100. And that means that with nitrous, what you're delivering in terms of nitrous to reach an alveoli of 100 is about 13%. So we're delivering 13% nitrous, and you can see that the equilibration occurs a lot quicker than oxygen. And the reason for that is that nitrous is 14 times more soluble than oxygen. So nitrous is 14 times more soluble than oxygen. Okay, and that is through the diffusing membrane. So it's 14 times more soluble in the diffusing membrane than oxygen. Now with CO2, this is what you guys are all here for. Okay, so the way I'm going to work it out is, what is alveolar? The first question I ask myself is, what is alveolar CO2? Well, alveolar CO2, I would say, is about 40 millimeters of mercury, just rounding off, just to keep the numbers easy, okay? And then I ask myself, all right, well, this point here represents mixed venous O2. Well, what is mixed venous O2? Mixed venous O2, which you know is also 40 millimeters of mercury. Great. Having that symmetry is really good, because that allows me immediately to think, all right, well, alveolar O2 will sit, will sit on this line here. I just gotta be careful not to put my thumb on this, otherwise we'll go to the next page. There we go. Okay, and then I will label this as CO2. Now, my next question that I ask myself is, okay, well, what is arterial CO2? What is, apologies, a mixed venous CO2? What is a mixed venous CO2? And mixed venous CO2, again, just for just rounding off, okay? Because the numbers might be sort of 45 to 42, but I'll just say 45 just for this diagram here. So that would mean that would start about up here, all right? And then the next question I ask myself is, all right, well, how does the carbon dioxide solubility compare to that with oxygen? And we know that CO2 is 20 times more soluble through the 20 times more soluble through the diffusing membrane than oxygen. And that would mean that because nitrous oxide is 14 times, and you can see the equilibration happen a lot quicker, that means that CO2 by logic should equilibrate even quicker than nitrous. And therefore I would have my graph of the CO2 looking something like this. All right. And that would be my CO2. My CO2 curve. And that is pretty much the steps that I go through to draw this CO2 graph on this curve here, okay, using these principles here. And I believe that this is what it will look like. Now, here comes the complexity when discussing about CO2 as a gas that is perfusion limited. Now, CO2 has a diffusing capacity 20 times that of oxygen. And generally thought to be, that is a mistake there. This is meant to be now, it's generally thought to be perfusion limited, as the alveolar gas equals the N pulmonary and capillary gas. However, this really ignores the importance of CO2 carriage in blood. And what has been shown is that, when you think about the mixed venous and arterial CO2 and alveolar CO2, the difference is only about 5 millimeters of mercury. So even if there is a 20% change, so unlike the oxygen, so alveolar oxygen is 100 and arterial oxygen is, so mixed venous oxygen is 40 and alveolar oxygen is 100. So you can see that difference is 60, whereas mixed venous CO2 is 45 and alveolar CO2 is 40. So the difference is only 5. So even with a 20% change or a 20% sort of pathology that causes a 20% change, there is only 1 millimeter of mercury difference, and that is of minimal significance. And the importance of CO2 carriage in blood is also important. So CO2 is carried as dissolved, as bicarbonate and carbamino compounds. And there has been studies sort of shown where they've used acetazolamide to inhibit carbonic anhydrase. So that affects the uptake of or release of CO2 with bicarbonate. And what it actually shows was that there was a large increase in the arterial alveolar partial pressure of CO2. And therefore, it actually reduced the diffusing capacity of carbon dioxide. And that's quite interesting, because what that study was showing was that this, CO2 carriage in blood really plays an important role in the diffusion of CO2. Okay, so I think that, look, that question is very complex, and I think it's actually very hard to sort of talk about CO2. A lot easier to talk about carbon monoxide, and a lot more complex to talk about CO2. And even in West, it just has a couple of lines to sort of talk about whether CO2 is perfusion or diffusion limited. And ultimately, what I think is that the way that CO2 is transferred is that it's due to minute ventilation or due to alveolar ventilation. So in other words, if you increase your alveolar ventilation, you actually increase the amount of CO2 being transferred. And the other complexity is that we're not uptaking CO2, we're actually producing CO2. So that's the other layer of complexity, to this answer here. Okay, so, but I think for all intents and purposes, for this exam, if we follow the concept that what makes a gas perfusion or diffusion limited is whether you get equalization. So if you get equalization, then a gas is perfusion limited. If you don't get equalization, then it is diffusion limited. Great. Any questions on that? So let's have a look at the chat. Quest for knowledge never ends. Yes. Any questions on that at all?
Sam, can I ask a very, really very basic, simple question?
But, no, absolutely.
Yeah. The units used on the axes of the graphs.
With these, which graphs?
These graphs that one you've got there.
Yes.
Yes. Can I just check that when it says partial pressure on the y-axis, that's yes. The partial pressure in the capillary.
It represents both. So it is a very good question. So it represents both the partial pressure. It can represent both in the alveolus. So that's what this line is representing, as well as at the start of the capillary, which comes from mixed venous blood, and the end capillary, which is the pulmonary end capillary blood. Okay, so this comes from mixed venous, this comes from end capillary, this is the alveolus. And what it's saying is that during this phase here, a gas that is perfusion limited, it will reach equilibration with the alveolar partial pressure in here. All right. But if a gas is diffusion limited, it will never reach equilibration. In other words, you'll always see a pressure gradient between the two, such as The classic one is carbon monoxide. And that would also explain these graphs here. So at the end, if you don't get that equalization, then that shows that oxygen here is diffusion limited. And in here as well, at the end, so oxygen here is diffusion limited. All right.
So when that red line, when the red lines are meeting the dashed alveolar line at the top,
yes,
that's when equilibrium has been reached between.
That's right. Correct. So at this point here, where you get that equilibration, right? That means that is perfusion limited. Okay. So at this point here,
yeah,
perfusion limited. All right. At these lower levels, anything that happens at these lower levels here, okay, you become
diffusion.
Exactly, diffusion limited. All right, so basically everything here, diffusion limited. Yeah, and the you can see the they've numbered it here 150, 050, but they haven't numbered it here. And I think the reason why they haven't numbered it here is because of the use of nitrous, because we don't use nitrous at, we don't use nitrous at 13%. We use it at 20, 30%. Okay. But I think this is just a representation, and you could say it's 100, and I've just used the example that we're giving 13% of nitrous and just seeing that alveolar nitrous equilibrate. All right, so this is the structure that we're going to use. We're going to have a definition of perfusion and diffusion limitation, and then we're going to have to include in those definitions a couple of gases, but the ones to include, you have to include are CO2 and O2. We want to talk about Fick's law of diffusion, and then after that you want to talk about the factors that determine whether a gas is perfusion or diffusion limited, according to their partial pressure gradient, altitude, transit time, hemoglobin concentration, and cardiac output. And explain, and these are the sort of extra ones, explain with graphs using CO2 and O2. So what I would do is I would actually put this graph, this is me personally, I would put this graph after I've put in my definition of perfusion and diffusion limitation. And then he said that you also get an extra mark for saying using carbon monoxide to measure diffusing capacity. What I would do is I would probably put this concept underneath Fick's law of diffusion. That's what I would do. All right, guys, you're ready. 10 minutes starts now. So I want my definition of perfusion limitation. I'm going to skip a couple lines. I want to have my definition of a diffusion limitation. I'm going to have the graph below. I've got to a new page. I'm going to talk about Fick's law of diffusion, and on my third page I'm going to have factors that affect O2 diffusion with potential for it to become perfusion, to become diffusion limited. Okay. So perfusion limitation, I'm going to go, the gases are nitrous, oxygen, and CO2. So the definition is uptake of gas is dependent on blood flow, where P alveolar gas equals P pulmonary capillary gas. For diffusion limitation, I'll say the uptake of gas is dependent on the membrane using capacity, which I'll define as a dm, and when alveolar gas is more than gas. Right. So draw this diagram. So I've got a time 0.25, 0.5, 0.75, and then I've got partial pressure in mercury over here. End of capillary, start of capillary, we'll have alveolar, 100 millimeters of mercury. Draw this is N2O. This is oxygen, and we can pretty much draw this oxygen at normal, oxygen normal, and you know what? I've done this incorrectly actually. Should have drawn it from here. All right, there you go. This is, I have just drawn my graph incorrectly. So oxygen should happen here. This is O2 normal, O2 normal, and we are gonna have to rush this one here, and this would be CO2. Okay, so what I'm going to say is error, please see page 4. So fixed law of diffusion. Transfer equals surface divided by thickness multiplied by solubility by square root of molecular weight times the change in pressure. So this equals dm, which is in mils per minute per millimeters of mercury. And for oxygen, diffusion occurs through one alveolar capillary membrane, dm, to reaction with hemoglobin defined by theta, and the volume of capillary blood known as VC. And carbon monoxide is used to measure DL, as its affinity for HB is 250 times that of O2, so that 1 over DL equals 1 over dm plus 1 over theta plus VC, where dm/CO can be calculated. So DL/CO can calculate the volume of carbon monoxide taken up by the alveolar CO2. Okay. And normal equals 25 grams per minute milliliters. Right. So my third page, my third page. That's my third page. All right. Causes of O2 diffusion impairment with potential for O2 to go from perfusion to diffusion limitation. So these would be a decrease surface area, e.g. emphysema, increase thickness, pulmonary fibrosis, decrease in the partial pressure gradient, such as altitude, correction rate with hemoglobin, decrease capillary transit time in exercise, so 0.25 seconds required normally for equilibration, decrease volume of capillary blood, and decreased concentration of hemoglobin, such as anemia. And I'm just going to put CO2 has 20 times diffusing capacity of O2, but mixed venous CO2 minus arterial CO2 difference is only 5 millimeters of mercury. So even a 20% change, 1 millimeter of mercury is of little significance. End of capillary. Start of capillary. Oh my God. Done. Oh my God, that was stressful. Unnecessarily stressful on my part. I don't know if you guys can see, but I drew the graph incorrectly on my first page, and that just completely screwed me up. So what I did was, if you can see, I started without even thinking. This is what happens when you just go on pilot mode. I started my O2 normal and abnormal on 0, and as I was going, this is not right. And the problem is I've had to redraw all this graph. So error, please see page, and that's right, I got error, please see page 4, okay? And my page 4 is here, which I've drawn it up here. Just label page 4. And I don't know what happened, but I structured my answer, and I'll have to rewatch the video, but I structured my answer on a third page, and my third page has gone missing. So I had a title for my third page subheading, which was causes of oxygen diffusion impairment, with the potential for it to go from perfusion to diffusion limitation, and yeah, it's gone. Okay, but yes, anyway, this is the real deal. Anyway, look, I think I got everything down in the time I want, in that time, including trying to correct my my mistake on that graph there. But yeah, This is all the bare bones of this answer here. All right. And I'll ask
Stan?
Yes, tell me, ask me.
Just with your error graph, if you were
Yes.
really tight for time, could you actually just, almost just change the
So
y-axis?
such a good question, Pip. Like I was looking at it and I was going, is there possible for me to change this graph? And then I thought, and conceptually in my head, I was going, all right, well, that would mean that I have to draw it here, and I draw it here, and I have to scribble this one out. And I think it just gets too messy.